This is Alexander Vincent. I'm going to be providing the virtual introduction today. I'm really excited to be welcoming our speakers. I first of all want to welcome you to the Learning Health System Collaboratory, especially on behalf of my co-chairs, Chuck Friedman and Ed Hurwitz. As you can see, today's session is being recorded and it will be available on our YouTube channel. If you'd like to subscribe to the YouTube channel, you can scan this QR code that you see on the screen. Next slide, please. Great. So if you're joining on Zoom, and I see we have a really nice Zoom crowd today, please do us a favor and keep your mic muted when you're not speaking. We'll have a lengthier Q&A today, so I'm hoping that you'll jump in then. Next slide, please. Okay, so this is the, we had many of you joined us last month for our annual kickoff, where we had a poster show and we had sort of a broader discussion in conjunction with our Melstar Symposium. But this is the first true quote unquote collaboratory talk of the year. And it is the first talk in our theme for this year, which is articulating the value proposition of the learning health system. This is a very exciting theme that we developed last year as we sought to think about all of the different ways in which someone could think about value and think about reasons to build a learning health system, as well as anticipate some of the challenges and opportunities of building learning health systems in academic medical centers and beyond. So when we were thinking about value, and I imagine when you think about value too, one of the first things that comes to mind is the economic value or a financial case or a business case for a learning health system. And we realized that although there's a ton of expertise in DLHS and in the health system more broadly, we're not always thinking about disciplinary economic approaches to understanding cost, or maybe some of us are and some of us aren't. And so in order to create common ground and to start us in the heart of value, we have two wonderful speakers with us today. Next slide, please. We are going to be speaking about the value of an economics approach to the value of the learning health system, as I mentioned before. And so we have our two speakers who are joining us today. We're very lucky to have Edward Norton and Helen Levy with us. Edward Norton is the United Healthcare Professor of Healthcare Management in the Department of Health Management and Policy, and a professor in the Department of Economics here at the University of Michigan. He's a member of the Institute for Healthcare Policy and Innovation and Director of Quantitative Analytics in the Center for Healthcare Outcomes and Policy. In addition to his affiliations with the University of Michigan, Professor Norton is a research associate of the National Bureau of Economic Research in the Health Economics Program and in the Economics of Aging Program. Dr. Helen Levy is a research professor at the Institute for Social Research and the School of Public Health, also here at the University of Michigan, with a courtesy appointment at the Ford School. She's a co-investigator on the Health and Retirement Study, a long-running longitudinal study of health and economic dynamics at older ages. Her research interests include the causes and consequences of lacking health insurance, evaluation of public health insurance programs, and material hardship among older Americans. She's a research associate at the National Bureau of Economic Research and has served as a senior economist to the President's Council of Economic Advisors in 2010 and 2011. I'm really looking forward to this presentation, and I'm looking forward to tying in the Q&A together what they present with us to some of the broader discussions that we have been having about establishing learning health systems and thinking about the value of the learning health system approach. So without further ado, I'd like to welcome our speakers to the podium. Thank you very much.
Thank you very much, Helen. Helen and I are really happy to be here today and to talk about cost-benefit analysis in healthcare, at least to give an overview and to give you some ideas about how economists think about the world, and in particular, thinking about making trade-offs for different decisions. So we want to start with the idea that people basically have unlimited wants of I want better food, I want to go on vacation, I want nice clothes, I want this, that, and the other thing. But resources are limited. If I want more, I need to pay for them. And so decisions will require trade-offs, often around money or time, to make decisions about what to do. And this is extremely important in healthcare. And what we want to do today is talk about some of the tools that economists have developed for this kind of decision making. So, for example, the kinds of decisions we'll talk about could be used for choice of treatment for disease, not just surgery versus medical drug treatment, but which kind of drug or which kind of surgery and the follow-up and pre-surgical care and so forth. Which drugs to include on a formulary have real consequences for a number of people. Should a hospital expand and have a whole cancer center or not, or a new children's hospital as was built here roughly 15 years ago? Should a physician group integrate with a hospital or be bought out by private equity? There are different ways that small businesses can go to make decisions about how to grow. Should an individual patient quit smoking or not? And should a government pass a new bill? These are all decisions that have multiple possible ways of going. And so the basics of cost-benefit analysis revolve around how do the benefits compare to the costs? And so at a very simple, superficial level, this is a very simple thing. What are the benefits? What are the costs? We compare them. We want to also think about social welfare as the sum of the benefits and costs over all of the relevant people. It could be a single individual making a decision about smoking or treatment for their disease. It could be their family. It could be all of society. And so the net benefit would be the sum over all relevant people of the benefits and costs. So far, this is all very simple. We just know, all we have to do is figure out the benefits, we figure out the costs, and we're basically done. Of course, that is extremely difficult, and there are a lot of challenges in trying to figure out costs and benefits. One of the assumptions here, though, is that we need a common currency, so to speak, to be able to compare benefits and costs, where benefits are truly often in terms of health or life years that are not naturally enumerated in dollars or euros or any other currency. But in order to compare them with costs, we want to measure them often as a willingness to pay or the value to the various individuals. And then if we do compare benefits and costs, and the net benefit, that is benefit minus cost, is positive, then that particular action would be deemed admissible and worth doing. If there are multiple different courses of action that someone could take, we'd want to do the one with the highest net benefit. Okay? So that's, I think, fairly straightforward if you can measure the benefits and the costs. Now, I'm not going to go through all this. Don't worry. This is adapted from a source that sort of lists a very formal cost-benefit analysis and all of the steps one would do, defining alternatives and time horizon and so forth and so on. We're not going to do that today. What I do want to talk about are 4 specific things within this list that I think are particularly interesting to think about and maybe a little less obvious for the non-economists. So we're going to talk specifically about these 4 things. Whose perspective are we talking about when making a decision? Is it individuals? Is it societies? Is it a business? Is it the doctor? And the difference between cost and price and the challenges on the cost side of trying to figure out what goes into the cost part of the formula. And then on the benefit side, trying to come up with a value of life or quality of life and enumerate that. And finally, discounting the future is something I think is fairly straightforward, but is sometimes forgotten. So those are the four things I will talk about, and then I'll turn it over to Helen, who has some interesting examples of how cost-benefit analysis might be used or has been used for various decisions, or perhaps misused. You can decide. All right, so whose perspective are we talking about? You can imagine a patient, and by the way, this is very much not a complete list of possible people or groups having a perspective or a list of things they might consider. But for example, when a patient decides a course of action or treatment, they're interested in their out-of-pocket costs. And if they have really good insurance or have gone through their deductible, they may face little or no marginal cost. And have a very low out-of-pocket price. Others, if you don't have insurance, may face a very high price. And what are the improvements in health that they are likely to get from that? Are they going to get greater life, reduced pain, better mobility? What are the likely outcomes? For physician, we think they care about their own income. Decisions may affect physician ratings. They may also truly care about their patient's health. We don't want to dismiss that. And so how do physicians work as a patient's advocate to make decisions? Hospitals will care about the revenue and the costs, but also their pay for performance ratings and serving the community. Insurers, we know, not only care about the cost and want to keep the costs down, but not just the initial cost of treatment, but what is this going to do for future costs, follow-up care, rehab, and so forth. They would care about that to the extent that they are liable. And the taxpayer is an important perspective that is sometimes forgotten. But for example, when people have Medicare coverage that is quite generous and may allow people to get services or equipment or treatment that has possibly very low marginal value to them, but is very expensive to society, that ends up being paid for by society through higher taxes. We want to think about and looking at various decisions from different perspectives may lead to different preferred choices of action. In terms of cost, yes, we care about cost. It's not always easy to figure out what a cost of an action is. What we want is the true economic cost, the value of all the resources that go into an action, including the cost of time. And that can be hard to measure. We often will use prices, DRG prices or other reimbursement as a proxy. But even for that, prices vary a lot. So you have the price paid for Medicaid, for Medicare, for different private insurers out of pocket. Those can be wildly different numbers. And the financial prices, if you only look at those for decision making, would typically not include the cost of time. And that can be very important, particularly for follow-up care and rehab and so forth. There's a huge trend in that. So I've already mentioned some of this, that the treatment costs may can vary a lot by depending on insurance. Medicare and Medicaid set their own prices. Medicare typically higher than Medicaid, and private higher than those typically. And some services, when they are bundled, may be free at the margin, but we don't think that their true economic cost is zero. So we want to be able to do that. And often we'll use some sort of average reimbursement rate as a proxy for the cost of a treatment, if that's what we're looking at. Cost could also involve future costs. If we're thinking about pollution, some activity today by a firm or a factory, which creates pollution, which may have downstream costs that will affect the health of people in the future. So value and quality of life is often useful for benefits. These are not the only benefits, of course, but are particularly salient in a health and healthcare setting. When if your only goal is to minimize cost, then you're leaving out the important benefits of how does this improve people's life, and minimizing costs as a pure goal typically means just don't do anything for the patient, let them die or go untreated. That's a terrible solution. Valuing the benefits is really important. And so two of the most common ways that benefits play out are extending life and improving quality of life. Could be lower pain, more mobility, not being sick, able to think more clearly, and so forth. And so we need to come up with a financial value of life and of health. And there are a number of ways that economists have done this. It's certainly not controversy free, but there are ways of asking people lots of questions to trade off time and money, or money and years of life, or health, more or less, and do various trade-offs. There are ways of looking at what people actually do in terms of their employment in more or less risky jobs. People who have very risky jobs in terms of mortality will typically be paid more, and so we can compare how much more do you have to pay someone in order to take a job that has a considerably higher mortality rate. And so the value of a life year is typically on the order of 100,000 or maybe a little more now. I think these numbers are a little old. Value of an entire life in the some number of millions of dollars. These are ballpark numbers that are typically used if you're looking at population level decisions about whether to do some action that would affect lots of people, and these numbers can be useful. There are also ways to try to measure different mental and physical health conditions and how they compare to full health. Helen has a really interesting example around that and some of the challenges around that. So again, bottom line, in order to compare benefits to costs, we need to evaluate benefit in the same currency. And so economists have found some ways to quantify additional years of life and additional healthy life years. And another idea, discounting the future. Very often these decisions involve outcomes that we expect not only to happen just immediately, you get treatment today and you go home and everything's over, but may affect things that go on for weeks and years and even decades. And so we'll want to think about discounting the future relative to today. The basic idea here is that $1 today is worth more than $1 in the future. Okay, so if I said, well, I can give you $1 or $100 today, or I can wait and give this to you in the future. There's a lot of uncertainty, if you may have noticed, in the world today. And are we going to make it to the future? And most people would much rather have the money now, thank you very much, than to have to wait to get the money in the future. And so the basic idea of thinking about any sort of benefit that's in the future, we want to discount the future depending on how far away it is in terms of time. So if you think of a future value, that would be discounted by 1 over the discount rate raised to the power of t. So for example, a typical discount rate would be something like 3%, a relatively small number, not 50% or 100%, but a relatively small number. After 10 years, or thinking about something in the future, it would be discounted about 25% back to the present with a 3% discount rate. Or for 25 years, about roughly a 50% discount. And 100 years in the future is almost completely worthless because my guess is very few of us will be here in 100 years, although hopefully there will be something left for our children and grandchildren. So we put more weight on the present, less on the future. And so going back to this slide, if you like a different discount rate, like a higher discount rate would be for someone who really puts more emphasis on the now and doesn't think or care so much about the future. In which case the future would be discounted further. But when thinking about planning over a long period of time, discounting the future is very important for adding up benefits. Costs as well. Future costs would also be discounted. Okay. I've reached the end of my slides. I'm going to turn this over to Helen Levy.
Can you hear me? Okay, great. Okay, that was amazing. Edward just condensed material so when I have taught this to master's students in the Ford School, that was like 5 or 6 weeks worth of material. So if it felt like kind of a lot, it was, and that was incredible. I've taught with Edward before, and I know how good he is at it. I have the comparatively easier task of just sort of kicking around some ideas with you about how cost-benefit analysis is or isn't used in the healthcare sector, and some of the sort of difficult questions that arise when you try to apply these methods. So cost-benefit analysis, and in general, the economic way of thinking about these types of things, thinking about value, it's a very specific, it's a very precise quantitative tool to be used for a specific purpose. And I think when people talk about value in healthcare, it's a much broader concept. People mean lots of different things by that. When economists talk about cost benefit analysis, we mean something really specific. Value in healthcare is something much broader. That said, there is overlap. And I think one of the most interesting areas of overlap is sort of the question of, well, value for whom? So whose value are you thinking about? And that question maps directly into what in the terminology that Edward used, because that's how you do it in cost benefit analysis, is whose perspective are you taking? And one feature of our American healthcare system is its fragmentation. And that word fragmentation also gets used in a lot of ways. But what I mean is that we have a lot of different payers for healthcare, as you can see in this pie chart. So all of those payers have a different interest, a different incentive when it comes to thinking about value. And as a result of that, there's really almost no one who is thinking about lots of people talk about value in the American healthcare system, but actually their incentive is to think about value in the particular slice of it that they are working for. And from cost benefit analysis, you would say almost no one takes the societal perspective. So if you think about different organizations and sort of where they're coming from on this, like, are they taking the societal perspective? The answer is no. Even for organizations that you would think sound like they should be taking a sort of not global, but national perspective on this. For example, the Congressional Budget Office, which I'm a huge fan of. They're often referred to as, Congress's scorekeeper or the nation's scorekeeper. What they actually count in terms of costs is federal spending. That's their mandate. They don't discount it. And also it's for 10 years. That's what the law says they're supposed to do, and that's what they do. They do also provide a lot of supporting analysis about what goes into those estimates, and frequently that includes some of the pieces of what you would need if you wanted to actually say what are the benefits of this legislation as well as its costs. For example, when CBO scores legislation about changes in health insurance, they will show how many people will lose or gain health insurance as a result of a policy. And they will present that next to a table that shows how much it's going to cost the federal government. So it's sort of like a rudimentary cost benefit analysis, except you're not attaching actual dollars to the value of gaining health insurance, which is a difficult thing to add values to. But it's not really their mandate to do an actual analysis of trading off those benefits and costs to inform Congress. We've delegated those decisions to Congress about what the benefits of a policy are, and the CBO provides them with the federal costs. So that's just one example of a group that sounds like it might have sort of a, a broad perspective on this, but it's actually a lot narrower than you think. And all of these other, I won't march through all of these, but all of these organizations, all these different entities have different incentives, and none of them actually has the incentive to take the sort of system-wide view of what drives value in healthcare. Medicare kind of gets the closest with the work that has mostly been piloted through their innovation center. I'm going to talk a little bit about some of that later. But otherwise, most of these organizations, it is built into their mission that they're either profit-making entities or not-for-profits that behave a lot like for-profit entities. And it's just not part of their mission to think, is this creating societal value? So does anyone take the societal perspective? Well, weirdly, federal agencies do, as a result of an executive order dating back many decades. When Congress makes a decision, they don't really have to explain the cost-benefit trade-offs underlying it. However, when the regulatory agencies act to implement congressionally enacted laws through regulation, if it's an economically significant regulation, which at this point, because they haven't updated the number that they use to define that, is basically any regulation of any size, there has to be an accompanying cost-benefit analysis. It's called a regulatory impact analysis. So for example, if you want to do something like put a graphic warning label on cigarettes, the agency that's doing that, the FDA, would have to show a cost-benefit, and it's the costs and who they fall on, and the benefits and who gets the benefits in the aggregate. And environmental regulations are sort of the best examples of this, because they show the trade-offs between how regulations are going to hit business profits, reduce business profits, but the benefits that they have for human health. So those are, I think, the environmental regulations. It's a little better developed over there than it is on the purely health side, how they think about the trading off costs and benefits in terms of policies. There's not surprisingly, other countries that have less fragmented healthcare systems actually do more of this. So it's not the UK, it's England and Wales. Weirdly, I don't know why, but that's what it is. That's who the NICE applies to. They take a societal perspective on healthcare coverage decisions for the National Health Service, and they use cost effectiveness thresholds, like, does this thing deliver a year of better health for less than $100,000 to make their coverage decisions. And so that's a good example for the rest of us. Oh, so let me set this up before I switch to that side. Okay, so Edward and I, a couple of weeks ago, we had lunch to sort of game out what we were going to talk about. And I said, okay, I'll come up with some real world examples. And then after lunch, I got back to my desk and I opened my email, and there were literally in my inbox, there were 2 examples that I was like, oh, this is an example of how it's not that they're like perfect examples of cost benefit analysis or anything like that. I was just like, this is the kind of thinking where, you could be thinking about this in different terms. And this was the first one. And this was actually in the university record on that day a couple of weeks ago. And the headline was that an accountable care organization had saved Medicare nearly $35 million in 2024. And how many people are familiar with accountable care organizations already? Okay, great. That's about what I figured. So basically, this is an innovation in care delivery and payment that was piloted through CMS as part of the Affordable Care Act, building on a demonstration project that had actually had a successful site here at the University of Michigan before that. And the basic idea is you have a group of providers, and CMS figures out how much they've been spending on their Medicare beneficiaries. And it basically makes a deal with that group of providers. The group of providers is called the ACO, the Accountable Care Organization. And it basically says, well, if you can provide care for those Medicare beneficiaries at below the cost of what you have been providing, while maintaining the same level of care as measured by specific benchmarks, we will share those savings with you. So the Medicare program where they contract with ACOs is actually called the Shared Savings Program. And the thing, like the benchmarks are risk adjusted. There was a lot of research that went into it. I think it was about as well as the program could have been designed. And what I liked about this headline, and I'm a little bit making fun of whoever wrote this headline, and I apologize for that because I admire, I know and admire this writer, and I don't think she probably wrote the headline. But the headline says the Palm ACO saved Medicare nearly $35 million. And if you look at the next line, it says, well, but actually half of that gets rebated to gets kicked back to the provider organization. So I would not actually call that saving Medicare $35 million. I would call that saving Medicare $18 million. So this is sort of an example of the slipperiness of when you talk about savings, for example, relative to what, right? And the point that Edward went over necessarily quickly was, what's your benchmark? What's your counterfactual for figuring out what the spending, what the cost of something was? So this is an example of how you have to be really careful in the policy space to make sure you're actually measuring correctly what something just as simple as what did something cost relative, which line on the budget are you gonna look at? And the other thing about this is if you had wanted to do a cost benefit analysis of this activity, first of all, you'd have to be careful to correctly say that the cost savings were not the full 35 million, but you'd also have to value the possible change in benefits, which would be the health of the enrollees, right? And so in this case, what we're doing is we're saying, well, we know the quality markers didn't get too much worse because that was part of the contract, but we don't actually know if there were changes in their health on, for example, other quality measures that aren't measured by the shared savings program. So if you actually wanted to do a full cost benefit analysis of this, it would be a whole lot of work, and it might yield a different result than what the headline suggests. And I apologize if anyone is affiliated with this ACO. I really admire the work that Medicare has done in this program. I just think the marketing of it is sometimes a little bit overblown. Okay, and then I also, in my inbox after this lunch that we had a few weeks ago, had an email from The Bridge, which is a publication that I really like that covers Michigan public policy. And it basically said, well, Michigan Medicaid just announced that they're gonna stop covering GLP-1 drugs. And the article actually said they didn't do any, the MDHHS said, no, we didn't do any analysis of this, we just need to save money. And so they cut these. And this will likely mean worse health and possibly shorter lives for the Medicaid enrollees. It may mean more costs for Medicare in the future. It's hard to say. It might actually mean less cost if people die enough sooner as a result of not getting these drugs. And I'm going to come back to that point later. But, was this a good decision from a societal cost benefit perspective? I have no idea. There is a paper out there in the literature that concludes that at current prices, the GLP-1 drugs are not cost effective, which is to say they concluded that they don't add a year of healthy life at a cost of less than $100,000. That study may be accurate, I don't know. By the way, this thing about maybe it would save money if they died sooner, that's why nobody likes economists. It's because we think like that. And and as a further example of that, something that Edward and I both came back to when we were having this discussion of how should we talk about value is this classic paper. It's an old paper in the literature that talks about taxing cigarettes and alcohol. And it distinguishes between the costs that the smokers and drinkers themselves bear and the ones they impose on the rest of society. And like, long story short, it basically concludes that smokers are basically paying their way in excise taxes. And that's mainly because smoking kills them before they have time to claim a lot of Social Security and Medicare. Whereas the drinkers are imposing a lot of costs on the rest of us. And that's mainly because they cause car accidents and it doesn't kill them enough to save the money on Social Security and Medicare. So again, that's why nobody likes economists, but that is how we would actually think about a cost-benefit analysis from the societal perspective. And it's also why you have to be super careful never to say something will save. The reason to do something is that it will save money, when what you mean is that it's actually good for people's health. So for example, people often make this argument about providing health insurance to children. Oh, we should do this because it will save money. And there is actually some evidence of that, but in the long run, it might not. And you don't want to have staked your argument. You don't want to have staked your advocacy on an argument that will actually turn out to be, well, we should just mail everybody cigarettes because that would save us money in terms of Social Security. I think I should probably stop there. I just had one more thing to say. I'll take 1 minute to say it. Two problems with cost-benefit analysis. The cost-benefit analysis has unfairness baked into it, in part because most of the measures that we use of value are actually measures of people's willingness to pay for something. So Edward mentioned very briefly that how studies have measured the value of life is often looking at the trade-offs people are willing to make in terms of what they would have to be paid to take a riskier job. Well, the thing that determines how much money they're going to have to pay you to take a riskier job is how much money you have, right? How badly do you need that job as a lumberjack, as a truck driver? Those are the risky occupations. If you're rich, you don't need it as much. Does that mean that the lives of the rich are worth more than the lives of the poor? Those kinds of assumptions are baked into cost-benefit analysis. It's also true that most cost-benefit analysis has nothing to say about fairness. Is this a thing we should do? Who benefits? Who doesn't? Whose costs, whose benefits? Cost-benefit analysis as a framework is it's very powerful, and you can actually use it as a cudgel if you're an economist and you know how to use it to beat people into not raising those objections. And that would be wrong, and you should not be deterred by any economist who ever tries to do that to you. And there's a great book by one of our University of Michigan colleagues, Beth Berman, who's a sociologist in organizational studies, who has this wonderful book, Thinking Like an Economist, that basically shows how cost-benefit analysis sort of like run amok among supposedly progressive economists and also in DC as a tool that has made everyone completely lose sight of what the point of any of these things is. And I think it's a brilliant reading if you have some extra time. All right, I'm going to stop there, and you want to come back and join me, Edward, and we can have a discussion about this.
You want to questions, or it looks like we can hear nothing.
Oh, I mean, I don't want to disadvantage people who I can't see because they're not in the room, but we're happy to call on people.
Why don't you say something? Great. Okay, raise the hand for the front. I'd like to start out with a question. It kind of makes me think about the LHS conferences for people. It is, the hospital spends a good deal of money on since they have no revenue stream. Quality office, safety office, the office of well-being, things like that. And those offices are, they work very hard, and you could actually spend 3 times as much, 4 times as much, 10 times as much, and they still be busy all day. So how does that figure in? How can hospital leaders figure that into these equations to understand how much they should be spending on these things?
Well, I guess I can think of 2 constraints. One is consumers demand quality, right? So assuming that the quality office does actually drive quality improvements or maintain quality in clinical care, presumably that's part of the business case that you're presenting to get people to come here. Since this is not a super competitive market for hospital care, but we do have a competitor on the other side of town. So as an economist, I would take comfort in the fact that the quality is probably higher because it has to be to attract people. And then the other constraint is that some of the government payment systems are built around meeting quality benchmarks. And I assume that office spends a lot of time making sure that's happening. And so you got to do it if you want to get the payment. So those would be the sort of, that's not exactly an inspirational talk about, and I assume people's mission as healthcare providers is to deliver high quality care because that's part of their ethos. But that would be, those two things would be the business case for it.
So in addition to aiming to have great quality, safety, and so forth to attract patients, I think also it's important to attract people to work here, right? And so my guess is there are many physicians, nurses, administrators who care about these things and want to be working for an organization that puts high value on that. And so to the extent that you're competing for doctors, nurses, administrators to work here, that could be an important part of recruiting and retaining people. That would be another part of the message, I think.
Well, not thinking about learning health system again. This is a very macro, as macro as it can get. It's about transforming institutions at different levels of scale. How do you think about value at a macro level? Is there your formula at the very beginning? Use individuals as an index. Do you think differently about value when you're thinking about effects that might manifest themselves across Michigan medicine, across the whole state, across the whole country?
I don't think so, other than the sort of obvious, the number of people affected would be greater as you moved out from Michigan medicine to the whole country. But the basic ideas of how you would try to calculate that with lives saved, lives improved, and the cost to achieve that, I think the basic tools would all be the same.
So, I'm sorry.
No, I want to ask you all a question. What is a learning health system?
I figured out. You know, this is an idea that's been around for about 18 years, and it was growing nationally and internationally, and adopted, and basically refers to the capability of a health system to continuously learn and improve itself. So it's a data and knowledge exercise. It's putting that knowledge to use. It's then learning from that use creates new data in a cyclic improvement process. And I'm sure learning health system, in my way of thinking, they'll have a lot of those going on at the same time, addressing different problems at the same time. And they will all be supported by an infrastructure that provides services that supports all of these concurrent efforts, because structurally they're all doing the same thing. They're taking data to knowledge back to data. So you can do that, and there are examples of this at all of these different levels of scale. Learning systems at the hospital level, or systems at the Michigan medicine type system. Indiana has a statewide learning health system because they have a statewide data exchange that is very sophisticated. Many Canadian provinces have learning initiatives, and some nations, such as Switzerland, have learning health system initiatives at the national level of scale. So when you think about what perplexing me and sometimes keeps me up at night is how do you think about value at a system level a lot of which is based on arguments that are creating a potential for things to happen that you can't predict in any kind of scale.
I wanna reframe that slightly, because in economic terms, one thing we think about is how concentrated our markets. And there's a trade-off. So competition, like in competitive markets respond to consumer preferences to keep prices low and quality high. In non-competitive markets, that doesn't happen. On the other hand, there are situations where competition isn't really feasible just because you don't have enough density of demand. And I realize I'm using a lot of jargon, but basically what it boils down to, like if you're only going to have one hospital in the area, competition's not doing anything for you. And in that case, particularly when you have government as like almost a 50% payer, you end up being better off if you just use the brute force of the government as a payer to dictate what is going to happen. And in American healthcare, I hear some sort of I hear attention about scale, basically, and what you're saying about the learning health system. And I think it reflects this economic uneasiness between, do we rely on markets to deliver high quality, reasonably priced healthcare, or do we rely on the government? And in the US, we have a sort of, horribly uneasy relationship with both of those things.
Taking maybe another path out of this idea of cost benefit analysis within a learning health system. Are there decisions, or when are decisions too small or too large to take a cost benefit approach? I think you outlined for us a nice sort of framework how to do it, and Helen, I like the example. It sort of made a lot of sense. And you could imagine getting a lot smaller with your decision, or you could imagine getting much bigger. How do you decide when you do and don't do this? And maybe the more important question, do we have the person power to actually do those analyses for all of those questions so that we can be informed in how we move forward? Or do we just do it without the analysis, as was done obviously with the Medicaid example, and just move forward? And how do we think about that from a system level?
Well, starting with the easy part of that, at the small end of the scale, economists think that everything we all do every day is a cost benefit analysis. So when you walk into CVS and you're like, am I going to buy those remainder Halloween themed peanut butter cups? And you're like, oh, wow, they're only $3, normally $6. You just did a cost benefit analysis. And I know that your value of those is somewhere between $3 and $6, right? So like everything looks like a cost benefit analysis to us. At the bigger end of the scale, there are no decisions that would not benefit from using this framework to think about the decision in a systematic way. Whether people actually have the resources to do those, I think, is a different thing. On the other hand, you can get a really long way just with some of these concepts. Like just these ideas of sort of what is the value, what is the actual cost, like a little bit of economics is, you don't need that much for it to be super useful, I think.
Yeah. Another potential constraint would be data and the quality of the data, and can you measure things? And do you ignore something completely? Like, we don't know the value of a patient's time to have follow-up visits, so do we leave that out, or do we make some reasonable assumptions to do that? And my guess is that the larger you get, the harder it is to collect reasonable data. But the data limitations can be a real constraint, I think, in doing the best possible job.
And the cost benefit analysis, very helpful. Think it into framework. A lot of people you're talking about. There's costs and benefits. Think of an academic research setting, because it isn't just providing care, which care should be provided, and measuring that outputs of care. There's also how are we going to fund registries, databases, new research that leads to new knowledge that generates new care. There's cost benefit analysis. This is being provided at each stage of
Is it worth checking on what are we doing? Is it worth assembling that information and publishing and distributing it? That links the whole NIH and cost benefit analysis there going integrating with the healthcare system. Have any observations about our somewhat aligned system for pulling this bigger picture of the developing healthcare?
Go ahead.
So we have a way of thinking about that. So the things that you described, for example, the creation of scientific knowledge through research, we think of that as, well, you could think of it as an externality, a positive externality. It provides knowledge to everybody and other people will benefit from that. Or you could think of it, we sometimes think of it as a public good, something like a highway that absolutely everybody benefits from. Depending on how applicable how widely applicable the knowledge created is. And so in a cost benefit analysis, you would think of positive externalities or public goods that were created as a result of, say, federal funding as a benefit. And they accrue very broadly, right? And so it depends how broadly the entity that's funding the activity thinks about its mission. So for example, if you are the NIH for however many decades it's existed, you think very broadly about the value of the creation of knowledge. If you take a more narrow approach, like more recent NIH administrators, and you say, well, this has to have a value for us. We don't see the value of creating all this stuff. The whole world's been free riding on us. Basically what you're saying is, I don't count the well-being of people who would benefit from this in my cost benefit analysis. So it's an extremely narrow view and it's not actually how the world functions. So we do have a way of thinking about those spillovers and they are important for thinking particularly about what types of public investments should be made.
Yeah. So it's just with that example, thinking of the late Bartlett and ECMO, as I understand it, developed here, but is obviously used far beyond the walls of Michigan medicine and has had tremendous health benefits to people all over. Yeah, how do you value that? Is that something you want to think about in your calculations of should we fund this lab science or not? But as Helen said, hopefully NIH is thinking about exactly that question of funding innovative research that may or may not have benefits in the short and long run. So hopefully NIH is doing that sort of calculation of trying to fund and support really innovative science that ultimately will have big spillovers to large populations, even though individual hospitals or clinics or labs may not always have that perspective.
Thank you for your talk. Huge fan of you both. I'm curious if there's appreciation for cost benefit analysis and how it might influence kind of myopathy in decision making. There's more uncertainty the farther out you look, and so as you're calculating cost benefit, I think thinking too far in the future becomes riskier. So does that kind of influence people to think too short term?
Yeah, and Helen's example with the year only going out 10 years, I think is very interesting. Their discount function is no discount, just you divide by 1 until you go out to 10 years, and then you multiply by 0. Like there's nothing beyond 10 years, which is really interesting. Certainly, the further you go out, the more uncertainty there is, and I think this could be more important to take into account if you are looking at very long run effects. Yeah.
It's also true that one of the current frontiers in cost benefit analysis, and this is more coming from the environmental debate, basically argues that it's immoral to discount future generations at the rate that we do. Because if you discount even a little bit, once you get 3 generations out, their benefits don't matter, right? It basically goes to zero. And that essentially on the environmental side, the side of things means just pillage. Because, you know, and so there are people who are arguing, and this is more like political philosophy than economics at this point, but they are arguing, you know, you shouldn't be discounting the well-being of future generations at all.
It gets a little hard. I would imagine, like, how far out in the world can you go?
That's why it's a philosophical debate at this point.
The sun will explode at some point, and there's nothing we can do about that. But anyways, that's an interesting point. I had not heard that. Even if we survive another several billion years, not likely this week.
There's a question in the chat from Sarah Greedy. She said earlier this year, there was a paper from the outgoing director of the CMS Innovation Center about spillover effects of the care models that have been implemented and evaluated, which suggested that the existence of the models created attendant but difficult to measure improvements in systems that had tested the model. How do cost-benefit analysis and economic analyses account for these so-called spillover effects? This was sparked by an example of the ACO cost savings.
Yeah, that's a great example of something that if someone were doing a cost benefit analysis of having an innovation center, which just as a footnote, if you go back and you look at the CBO score of the Affordable Care Act, which created the innovation center, it had like, and there were all these pilot programs, including the ACO one on that page of the budget score. And it's just like a page of zeros. Because they were sort of like, no one knows what these things are going to do. So how can we, our best guess of the impact they're going to have on federal spending is zero, which is probably unfair, but it was also a hard task to say, what are these things going to do? However, back to that specific point, in general, if you thought that that having a center to test these innovative things as pilots so that other systems can then learn from successful innovations, that would be another example of a positive externality or a public good. And you would want to value that in thinking about what the impact of those innovations and of the CMS Innovation Center in general would be. So you would sort of make your best guess about what those are going to be and add them all up. And if you're doing a retrospective cost benefit analysis, if it were possible to attribute changes in sort of system-wide to, for example, the ACOs that have pioneered different ways of reducing spending while maintaining quality, if you think that translates over into other non-ACOs, you would absolutely want to factor those savings into your analysis.
But that's really hard to do because the Innovation Center was new and different. Right. And so it's hard to look back at prior historical innovative centers and know what they would do in the future. So that's a really challenging task, getting back to Alex's uncertainty point.
Yeah. I have a question about value-based care delivery, and just if you have an opinion from your research and experience, those health systems that are really focused on value-based care versus patient service and putting processes in place to accomplish those deliverables, do you think they have a good sense of what that value is? I know a lot of that comes from the payer, but just curious your thoughts on this whole push to VBC.
The concern there is that it's the equivalent of teaching to the test, that they're maximizing a sort of short-term goal that has very specific measurements that may be able to be achieved and will hopefully do some good things, whether it's bringing down costs or mortality, improving quality in various ways, but then doesn't measure everything else, doesn't include other things that are truly beneficial for the population served, if not society as a whole. So I think it's the teaching to the test, and honestly not, the other part of this that doesn't get talked about as much, I think, is knowing what those goals and targets should be, and how are they determined, and is that getting us to the right answer? So it challenges there.
But I do think, I mean, I think CMS has done a great job of moving the value-based agenda forward. And I do think that it has, I mean, you guys could know better than I do, that it has sort of changed the culture of discussions around quality care. And I also think as a patient, you can recognize when a health system has people who are committed to quality. So I feel that as a patient every time I interact with Michigan Medicine. Is that because of the value-based payment systems? I don't think so. I think it's because that's the culture here. I'm an economist. I don't know where that comes from. You would need to ask someone else about that. But as a consumer of care, I know what that looks like. And I am happy to pay more for it if I have to.
Another question from the chat, this is from Josh Rubin. He asks, would the case of Henrietta Lacks represent an extreme example of the concerns we raised regarding cost benefit analysis and social welfare economics? Taking her cells undoubtedly generated tremendous value to society and to the health of many, but violated her autonomy while making some in power quite wealthy. More generally, how can we think about assessing value when various measures from public health to research on patients' de-identified data may also trample on some people's rights in the name of public good?
Okay, so that was obviously a tremendous violation of her rights, and I believe her family got a settlement, if I remember correctly what happened in that case, which is entirely appropriate. You know, was the settlement adequate? I don't know, but we do have a legal framework for when people's rights are violated that probably wasn't adequate to, you know, compensate them for that particular violation. I think when you talk about data and making, for example, you know, linking health systems data to some state database without explicitly consenting patients, these are tricky ethical questions, and the risk of identification of patients, for example, has to be everybody, you know, top of mind for everybody. Is some level of risk, you know, someone hacking into the system and getting everybody's data, which is of course a risk that we all face, is some level of risk acceptable in light of the types of system-wide improvements that it might generate? Probably. And in order to, I mean, I would say you do a cost benefit analysis to try to figure out what level of risk is acceptable, because you certainly wouldn't want to say we can never use patient data to learn anything, right? That would be antithetical to having a learning health system. On the other hand, you are legally and morally obligated to protect people's privacy. So as Edward said, trade-offs. It's always about trade-offs.
Yeah, I think about well-being, about physician staff turnover, doing things that increase the value of our work. I like to argue that learning health systems bring people together and help increase the value of work and increase well-being in the workplace. Could you comment on how you've been looking at these issues, physician burnout, as I talked about, in terms of how it affects the economy culture?
Right, so when there's burnout, you're losing, at least temporarily, someone employed who's doing valuable things. Then the question is, do they leave employment entirely? Do they come back? Are they less effective while they're trying to work? So if you think of a physician or nurse as an input into the quality of care, you want that to be as good as possible. So how do you create an environment where you don't have burnout? So again, there's cost and benefits. You want to invest in having a good environment, but still get the most out of it.
I'm not sure that question is really in our wheelhouse as economists, because this is another one of those ones that I think goes back to culture. Like the economic answer would be pay them more, right? And obviously, obviously that misses probably 90% of why people burn out, right? So it's about organizational cultures, I would guess, and motivation. And those are not things that we're good at thinking or talking about.
Officially, 9 minutes.
Oh, okay, good. Sorry, it's the some people.
Question though, do economists ever try to put a value on the culture? Because you're putting a value on, life. So you can put a dollar value on something if you want to.
So is that ever put in the equation?
I think the kinds of things that are more feasible would be looking at turnover rates and burnout and leaving the profession. And if you believe that the culture affects quality of care and handoffs and teamwork and so forth, then there may be ways to try and quantify that.
Yeah, I think that's a great idea.
Yeah.
And I actually think that there are people in the business school who do this. I just read an article about one of them and I forget his name. But there's been work, for example, this is not the same as sort of work culture, but an element of work culture is the diversity of the teams that people work in. And there's excellent quantitative work by our colleague Scott Page, who's a political scientist who works in complex systems and also at the Ross School, talking about the value of diversity for teams at work in terms of it's sort of a win-win. And I'm sure there is work, again, probably by people affiliated with Ross at this university that looks at workplace culture and how to quantify its benefits. I think that's a fascinating idea.
So our graduate program in this department is called Health Infrastructures and Learning Systems. I mentioned the word infrastructure before when I tried to describe probably unsatisfactorily what a learning health system is. Are there resources you can point to, maybe people here or elsewhere who have done economic analyses of investments in infrastructure specifically related to health?
I don't know there.
So there's like an industry of consultants who do cost benefit analyses. So you take something like, one of the examples I've used in my teaching at the Ford School is something like, should the Ann Arbor Airport make its runway longer? So there was like 1,000-page cost benefit analysis done to inform that question. And it was done by economic consultants who do cost benefit analysis for a living. So there are a lot of people who do this. I don't know if there are any who sort of specialize in the space that you're talking about, but that would, it would be very interesting to try to integrate the idea of the learning health system with some of these tools and decision models, because healthcare poses so many unique challenges for any kind of economic analysis.
So would some of the infrastructure be electronic health records, for example, not just buildings, right? Yeah. Parking.
More parking.
We have paper, in fact, Sarah Green takes one of the, no, actually, she wasn't co-author, I'm not taking, but we have a paper that talks about 10 services that a socio-technical LHS infrastructure must provide. One way to do this would be to do a cost benefit analysis of each service of the infrastructure, but that would ignore the synergistic effect of having these services working in conjunction with one another. I frequently ask, what is the benefit of having this infrastructure in place versus people who are building pieces of it but not thinking about it as a comprehensive infrastructure? And I don't know how to answer the question.
I think your biggest problem is likely to be that the benefits, it goes back to the point about creating knowledge. Your benefits are likely to be the creation of knowledge. And that has no value proposition for the organization, right? You have to make this is why it's hard to use cost benefit analysis to sell good ideas that benefit everybody.
Well, we do
Right.
argue that the goal of learning health system is better health.
Or then make that explicit, right? Because the costs will explicitly fall on whoever you're asking for money. And so you have to I would say you've got to make them be like, yeah, I don't actually care about all those people's benefits. And that's why I'm making this decision.
There are research networks that use infrastructure with the goal of producing better knowledge, which in turn will make people healthier, but the proximal goal is better knowledge.
Yeah.
I don't think the learning health system value proposition goes that way. It's all about making people healthier, at least when it's done right in the game.
This might be the last question. This is from Jason Seltzer. Based on the perspective of the team building or interpreting the cost benefit analysis, how do you eliminate bias in determining an outcome that is desirable to any stakeholder group? Any number of costs or any immeasurable value of benefits can be built into a model to effectively prove or disprove a value outcome. For example, an ROI of adopting an AI tool in nursing documentation. The hard ROI would never work, but the more benefits you include, the more favorable the ROI becomes.
Yes, that's exactly right. So this is a huge problem. This is much better developed in the literature on environmental regulations than it is on healthcare. But basically the idea is co-benefits. Like you just keep counting additional things as benefits. And this is why there's, this is why it's a hard thing to do right. And if you don't know what you're doing, it's an extremely hard thing to argue that someone has done wrong if they know a little bit more than you do. So the potential for misuse of this tool is boundless. And Jason, I apologize, is exactly right. You can sort of construct one of these to find almost anything you want to. So you have to be really careful both as a producer and as a consumer of these analyses.
Dr. Levy, Dr. Norton, thank you so much. This was fascinating.